Assalamu alaikum. Dear students, I am Dr. Istikhar Sajjad. I am currently working as Senior Registrar Pulmonology. Today, the topic which we are going to discuss is chronic obstructive pulmonary disease. So, first of all, we'll look on the definition of COPD. It is defined as the preventable and treatable disease characterized by persistent airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. This definition sums up COPD. If we look upon this definition, first part of this definition shows that this disease is a preventable and treatable. Preventable in a sense that if we prevent our exposure to the noxious particles and gases which causes COPD, we can be saved from having this disease, COPD. And it is treatable by the drugs. I'll just show you in the later part that what drugs we can use to treat this disease. Next portion is the persistent airflow limitation. It is the part which differentiates COPD from the asthma. In asthma, when we look upon the definition, we see that in its definition it is mentioned that the symptoms and limitation is variable over time and intensity. Sometimes it is zero or near to normal, and when there is acute attack of asthma, it approaches towards a very severe obstruction. But in COPD, this is progressive. It does not touches the baseline. It progresses with the time after significant exposure to obnoxious agents and smoking would be there. Then comes its pathophysiology in the definition that it is caused by an enhanced chronic inflammatory response in the airways and the lungs to the noxious particles or gases, especially smoking. So exposure of a person to these gases and noxious particles starts a chronic inflammatory response in which is not only in the airways but also in the alveoli and in the lung, which causes emphysema predominant COPD. If predominantly this inflammation in the airways, it causes chronic bronchitis predominant COPD. When we talk about the prevalence of COPD, it is directly related to the exposure to the risk factors in the community. If a person lives in a community where there is a heavy use of tobacco and there are smokers, the incidence and prevalence of COPD would be more there. Similarly, in an area where there are the coal factories and where there are factories where biomass fuel exposure is there, or in homes where biomass fuel exposure is there, its prevalence increases. COPD will present the seventh leading cause of disability and fourth most common cause of death worldwide by 2030. What are the risk factors which increases the risk of COPD among the persons? Among them, most common is tobacco smoking. It accounts for 95% of cases in the UK. Second is indoor air pollution, which comes from the biomass fuel exposure in the home while cooking when the food is cooked in confined areas where there is not proper ventilation. Occupational exposure is also very important risk factor for developing COPD. Those who are workers at coal dust area in the factories where silica and cadmium exposure is there are higher chances that they can develop COPD. Low birth weight increases the risk of development of COPD in the patients. Childhood repeated infections or maternal smoking can also increase the risk of development of smoking. Similarly, recurrent infections accelerate decline in post-expiratory volume in first second. Persistence of adenovirus in the lung tissue may alter local inflammatory response, predisposing to lung damage. HI infection is also associated with development of emphysema. Those who are living in a community where there are low socioeconomic status, they are also at high risk of developing COPD. Why it is like that? There are multiple factors for those people who are living below the belt. Low socioeconomic status causes malnutrition, which increases the risk of damage when exposed to some obnoxious agent. Similarly, these persons smoke crude tobacco as compared to fine tobacco, which again increases the incidence of smoking. Cannabis smoking also increases the risk of development of COPD. In addition to them, there are some host factors which enhances the development of COPD. Among them, alpha-1 antitrypsin deficiency is very important, which increases the risk towards development of emphysema. So now come towards pathophysiology of development of COPD. The presence of airflow limitation combined with premature airway closure leads to gas trapping and hyperinflammation, adversely affecting the parenchyma and the mucosa of the airways, and it increases the chances of development of COPD. When the obnoxious agents are inhaled, they affect the mucosa of airways. It leads to enlargement. When there is a chronic inflammation in the airways, it releases the factors which causes more and more inflammation there and leads to mucus secretion, hyperplasia of glands in the mucous membrane, and there is more mucus is secreted in the airways. There is also increase in number of goblet cells accompanied by an inflammatory cells infiltrate, which result in increased sputum production leading to the chronic bronchitis. And this is again, this chronic inflammation leads to loss of elastic tissue. Inflammation and fibrosis in airway wall result in premature airway closure, gas trapping and dynamic hyperinflation leading to changes in the pulmonary and chest wall compliance. Third component is emphysema development when there is an unopposed action of protease and oxidants leading to the destruction of alveoli. So these alveoli merge with each other, leading to larger size of alveoli. These larger size of alveoli results in decrease in the surface area. The surface area which is used for transport of oxygen from the air in the lungs towards blood and removal of carbon dioxide from the blood towards the airways. So patient get hypoxic. In addition to that, these chronic inflammation and smoking itself leads to the remodeling of the pulmonary vasculature and can lead to the pulmonary hypertension. These are complications which are caused by exposure to smoking in the lung. While the COPD also have systemic complications like there is muscular weakness reflecting deconditioning and cellular changes in the skeletal muscles. There is increase in the circulating inflammatory markers. There is impaired salt and water excretion, which leads to retention of salt in the body and leading to the peripheral edema. There is altered fat metabolism, which contributes towards the weight loss. In fact, In these patients, due to anaerobic respiration, protein is used in a larger quantity and the muscle mass is reduced in the patients of COPD. There is also increased prevalence of osteoporosis in the patients of COPD. How the patient presents to you? Usually these patients come in the later age of life, usually after 50s or 40s of years, with a significant history of smoking. The significant history means the smoking for more than 20 pack years. With this significant exposure to the obnoxious agents or smoking, they present with the history of cough, sputum production, shortness of breath, wheezing or chest tightness. Though asthma and COPD share all these symptoms, but when we take the detailed history of these patients, we see that all these symptoms in these patients of COPD are persistent. They do not vary over time and intensity, that these patients never say that they get completely normal. But yes, they say that they get relief after taking medicines, but when they leave the medicines, again these symptoms come there. So if the patient is not taking any medicine, these symptoms worse with the time. Those patients who are emphysema predominant, they are also called pink puffers. Their main complaint of presentation is shortness of breath. And while those patients who are chronic bronchitis predominant, they are also called blue bloaters. Their main symptom is cough and sputum production. What signs we can observe in the patient of COPD? It depends whether the patient is chronic bronchitis predominant versus emphysema predominant. When we look on the patients of COPD, we can, in general physical examination, we can see nicotine marks on the fingers as well as on soft palate. The lips are usually dark in these patients. They may be cyanosed. The chronic bronchitis patients are usually cyanosed, while emphysema predominant patients are not usually cyanosed. There is tachypnea, increase in the respiratory rate, breathing pattern, like emphysema predominant patients are the patients having severe COPD. Their breathing pattern is pursed breathing. While during expiration, they close their lips to generate a positive end expiratory pressure, which helps to maintain their airways pattern. In addition to that, they might be using their accessory muscles. When we look on the chest shape, they might have barrel-shaped chest with positive tracheal tug and reduced cricosternal distance. Their apex beat might be impalpable due to hyperinflated lungs. They might have decreased total chest expansion. While when we auscultate these patients, there would be vesicular breathing with rhonchi, or there might be decreased intensity of breath sounds. Patients with chronic bronchitis predominant COPD have predominant rhonchi, while those with predominant emphysema, they have decreased intensity of breath sounds. Features of carpulmonale like raised JVP, loud P2, tender hepatomegaly, pulmonary pedal edema, these features might be there. In addition to that, there is wastage of muscles in the patients of COPD. This is the scale called Modified Medical Research Council scale, which quantifies the shortness of breath in the patients of COPD. There are 5 grades. Grade 0 is no breathlessness except with strenuous exercise. At MMRC scale 1, there is breathlessness when hurrying on the level or walking up a slight uphill. Like when patient says that he gets short of breath while walking upstairs, or even at ground level when he runs or walks briskly. MMRC 2 is when patients say that he walks slower than contemporaries on level ground because of breathlessness or has to stop for breath when walking at his own pace. While those patients who have MMRC scale 3, they stop for breath after walking about 100 meters or after a few minutes on level ground. While those patients who are scaled as MMRC 4, they are too breathless to leave the house or breathless when dressing or undressing. But investigations can help us to diagnose a case of COPD. Among them, first one is spirometry. You might be aware of spirometry. In spirometry helps us in calculating different rates and volumes. For us, more important is forced expiratory volume in 1 second and forced vital capacity. Vital capacity is the total lung capacity except residual volume. Like total lung capacity minus residual volume is vital capacity. When a person exhales with full force, this vital capacity would be labeled as forced vital capacity. And during this maneuver, the amount of the air or volume of air which the person expires in first second would be labeled as FEV1. Normal value of FEV1 over FVC ratio is more than 0.7. When it is less than 0.7, there is obstruction. Among obstructive airway disease, two are more major differential. One is COPD and other is asthma. In order to diagnose a case of COPD, we perform bronchodilation test, that is, we nebulize a patient with 400 microgram of salbutamol via inhaler technique or 5 milligram of salbutamol via nebulization solution. And after 15 to 20 minutes, we repeat spirometry and assess the increase in the parameters of FEV1. If FEV1 is increased by more than 12%, this is called significant bronchodilation. While the patients of COPD don't have significant bronchodilation. If that is there, the patient is likely to be asthmatic as compared to COPD. So when there is obstruction, that is FEV1 over FVC ratio is 0.7 or less with insignificant bronchodilation, the patient is likely to be a case of COPD. Second is radiology. The chest x-rays are not routinely indicated in order to diagnose a case of COPD, but those patients who are emphysema predominant, there are certain changes in the x-ray chest. There is hyperinflation of the lung fields. That is when we calculate the anterior ribs. These are the anterior ribs. These would be 7 or more in the chest x-ray PO view with full inspiration. The lung fields are more black, that is, they are more hypertranslucent. The heart size is reduced, it is called tubular heart. The diaphragms are more flattened, and there is an increase in the intercostal spaces. These features suggest emphysema predominant COPD. CT scan is not routinely indicated in the patients of COPD, but they are only indicated when we have any other differential diagnosis malignancy, mass, or any interstitial lung disease in the differential of the COPD, or we are planning lung volume reduction surgery. Otherwise, in a routine, this is not indicated. This is iChart CT chest, high resolution CT of chest, uh, showing a barrel shaped chest, that is, his AP diameter and transverse diameter are nearly equal. This is a portion where there is a air trapping and it is compressing a part of the normal lung. So when we go for lung volume reduction surgery, we will plan to clamp or uh, put a valve in this segment. So its size would get shrink and the compression effect over the normal area, relatively normal area of the lung would be reduced, and this will help in improving the shortness breath. Other tests like DLC and DLCO, that is diffusion lung capacity for carbon monoxide, plethysmography, and echocardiography are indicated only in special circumstances when above tests like spirometry with the help of some radiology evidence does not confirm the diagnosis of the COPD. There is a spirometry classification of COPD showing its severity. In all, the baseline is FEV1 over FVC ratio should be less than 0.7. If this ratio less than 0.7, FEV1 percent predicted is more than 80%, it would be labeled as mild COPD. If FEV1 percentage predicted is in between 50 to 79, it would be labeled as moderate. 30 to 49 would be labeled as severe, and less than 30% of the predicted would be labeled as very severe. The Gold has classified these terminologies as stage 1, stage 2, stage 3 and stage 4. Similarly, NICE guidelines have labeled these stage 1, 2, 3, 4. Now we come towards the management of the patient. The first and basic part of the management is to reduce the exposure of obnoxious agents. That is, those agents which already cause COPD, the patient should be away from those obnoxious agents. That is, if the patient is still smoker, it can increase his or her level of COPD. So first step would be to quit the smoking. Second main agent in the treatment of COPD are bronchodilators. In the management of stable COPD, long-acting beta agonists or long-acting muscarinic antagonists are used. How we decide that which agent we have to give? Initially, if the patient, as we group those patients in mild, moderate, severe and very severe obstructive cases, those patients who are in mild cases or they are having rare symptoms, they can be managed on as needed use of short-acting beta agonist or short-acting muscarinic antagonist. While those cases with moderate level of obstruction, they can be managed as on regular intake of long-acting muscarinic antagonist, preferably as compared to long-acting beta agonist. Long-acting muscarinic antagonists include tiotropium or euclidinium. If the patient is not managed on alone, long-acting muscarinic antagonist preferably or long-acting beta agonist alternatively, that is salmeterol or formoterol alone, then we can combine both LAVA and LABA. If still patient is asymptomatic or on initial assessment, the patient is having eosinophilia in his complete blood count or sputum eosinophilia is there, we can add inhaled corticosteroids. Oral glucocorticoids are not indicated until unless the patient is having acute exacerbation of COPD, for which oral glucocorticoid like prednisolone is added for a shorter period of time, usually 5 to 7 days. These are added in long term only if the patient is not controlled by above all medications and get worse whenever his oral glucocorticoids are reduced. They can be given minimal amount of the glucocorticoids. Pulmonary rehabilitation is very important in the management of COPD. There are some exercises which should be told to the patient, and he should be encouraged at all stages to do those exercises, which are some breathing exercises which enable the patient to breathe in a comfortable way rather getting tachypnic and irritable. Multidisciplinary programs that incorporate physical training, disease education, and nutritional counseling reduces the symptoms. It improves the health status and enhances the confidence. Most programs include 2 to 3 sessions per week, last between 6 and 12 weeks, and are accompanied by demonstrable and sustained improvements in exercise tolerance and health status. Surgical intervention is indicated in special circumstances when the patient is unable to get improved by all above medications and having typical emphysema in uh, uh, preferably in the upper lobes of the lung. They are a better candidate for lung volume reduction surgery. In addition to them, those patients who are having single large bulla which is compressing over the larger lung, remaining lung, they are also an ideal candidate for bullectomy or lung volume reduction surgery. Both bullectomy and lung volume reduction surgery can be performed thoracoscopically, minimizing morbidity. Lung transplantation may benefit carefully selected patients with advanced disease. In addition to that, vaccination should be done in the patients of COPD to minimizing the risk of infective exacerbation of COPD. They should be vaccinated for both influenza virus and as well as pneumococcal bacteria. In addition to them, they should be advised to reduce their weight if they are obese. Palliative care is recommended for end stage patients. In the palliative care, we address uh, symptoms only. We go for symptomatic management, like morphine preparations may be used to relieve his breathlessness and anxiety status, and decisions regarding resuscitation should be addressed in advance of critical illness. Long-term oxygen therapy is indicated in those patients in the following circumstances. These are three indications when patient is advised long-term oxygen therapy. First one is his PaO2 less than 7.3 kilopascal or 55 millimeter of mercury, irrespective of PaCO2, and FeV1 less than 1.5 liter. PaO2 in between 7.3 to 8 kilopascal, that is 55 to 60 millimeter of mercury, plus pulmonary hypertension, peripheral edema, or nocturnal hypoxemia. The patient should have stopped smoking before advice of LDOT, because if the patient is smoking and oxygen helps in burning or itself burns, then it can cause a very huge explosion at that moment. The patient should remain on oxygen at least for 15 hours per day at a minimum possible oxygen to achieve his oxygen at more than 8 kilopascal or 60 millimeter of mercury without unacceptable rising PaCO2. This criteria should be filled at least on 2 occasions 3 weeks apart when patient is not in acute exacerbation. COPD has a variable natural history but is usually progressive. The prognosis is inversely related to age and directly related to the post-bronchodilator FEV1. This is the index which is used for prognosis, measurement of the prognosis of the COPD. It includes 4 things. B stands for BMI. More than 21 has 0 score, or less than or equal to 21 has 1 score. O is the level of obstruction which is measured by FEV1. More than or equal to 65% would be labeled as 0, 50 to 64% 1, and 36 to 49% 2, and less than 35% of predicted would be labeled as 3. This is measured on spirometry. D is the distance walked in 6 minutes. If patient walks more than 350 or equal to 350 meters, it would have 0 score. Between 250 to 349, it would have 1 score. Between 150 to 49, it would have 2 score, and less than 149 or equal to 149, it would gain 3 score. And last part is E exercise, that is MMRC dyspnea scale. If the patient is having 0 to 1 dyspnea scale, his points would be 0. For 2 mmRC, the point would be 1. For 3 mmRC, the points would be 3. And for 4, for 3 mmRC, the point in board index would be 2. And for 4 mmRC, the point would be 3. So if the patient with a board score of 0 to 2, a mortality rate of around 10% at 52 months is predicted. Whereas the patients with a board score of 7 to 10 has a mortality rate of around 80% at 52 months. This was all regarding the management of stable COPD. Now we come towards acute exacerbation of COPD. Acute exacerbation of COPD are characterized by an increase in the symptoms and deterioration in the lung function and health status. Basically, when the patients of stable COPD comes in the emergency department with the worsening of symptoms, worsening of any of symptoms including the cough, his sputum production, his shortness of breath, this would be labeled, and he is on his regular medication, then it would be labeled as acute exacerbation of COPD. There are many factors which causes acute exacerbations in the patients of COPD. Among them, most common includes the infection, which might be viral infections, bacterial infections, or fungal infections. Second include the exposure to high obnoxious agents, like he has exposed to high quantity of smoking or any obnoxious agents like biomass fuel exposure, chemical exposures, or any perfumes which causes increased obstruction level in these patients. So after whenever you receive the patient of COPD in the emergency department, you would take the short history including his past history. Patients tells that there is a significant history of smoking, and he was short of breath for a couple of years and is worsened for a period of few days, and he would also mention some risk factor for the exacerbation like fever, change in color of sputum, or a sore throat, rhinorrhea, or some exposure to the heavy amount of smoking. So you will assess his parameters. First of all, you will check the ABCD like his airways, his breathing status, and his circulation status. There would be tachypnea, there might be cyanosis there, and accessory muscle usage can be there. You look upon his oxygen saturations. If the patient is hypoxic and his oxygen saturations are less than 92%, you will add controlled oxygen, that is 0.5 to 1 liter per minute, and in the meantime urgently you will take a sample for ABGs and would send for gas analysis. If there is a carbon dioxide retention and patient is in type 2 respiratory failure, our target SpO2 level would be 88%, and you will give minimal possible oxygen which would enable him to keep his oxygen saturation at 88%. High amount of oxygen which results in more and more CO2 retention due to depression of the respiratory center, which is stimulated by hypoxia in the patients of COPD and chronic retained, those patients who have been chronically retaining carbon dioxide. Second component is bronchodilators. You will give repeated nebulizations with short acting beta agonist and muscarinic antagonists, and you will give IV glucocorticoids or parenteral glucocorticoids in the patients of severe exacerbation of COPD. If there is a definitive clue or any risk for being infective exacerbation of COPD, you will add antibiotics in this patient. In acute exacerbation of COPD, in acute hypercapnic respiratory failure, you will add non-invasive ventilation in the form of BiPAP. In non-invasive ventilation, there is a closed mask which delivers a positive pressure while the patient is breathing. This pressure is more during inspiration as compared to expiration, and it helps in opening of the narrowed airways and improves the ventilation till the smaller airways. And in this way, it helps in removal of carbon dioxide from the body and improves the oxygenation. Additional therapies like chest physiotherapy, or if the patient is not improving from the above mentioned treatments, he might be a candidate for invasive ventilation. In addition to that, a mucolytic agent can be added if there is a heavy amount of thick secretions are coming out. Thank you. If there are any questions, you can email me at dr.istikhar@gmail.com.